Hi guys, so JC and I are on 7.2 today, and we're talking about the development of an SOP for CCPs using nasogastric tubes or orogastric tubes. So we thought we'd just do a little video. I'll make some mistakes, please refer to the SOP as it's written down, but maybe just some tips and tricks rather than masterful advice. So we're going to be putting these tubes in people pre-hospitally. They're going to be intubated. The contraindications you can read in textbooks is the stuff that you see with MP airways, basal skull fractures. For me, I'd be concerned, and I just wouldn't do it in somebody that's got obvious history of head and neck malignancy, has had esophagectomies, has known esophageal varices. People like that, just stay away. But it's a nice add-on to do, and it's one less job for them to do in A&E, and it progresses the patient journey a little bit, I suppose. So there's a huge hoo-ha when I was a foundation trainee, so it's sort of 2011, whereby the incorrect and unidentified placement of an NG tube became a never event. So National Patient Safety Alert in 2011, I think. And so it is mandatory now in hospital before you use an NG tube, and by use I mean feeding, because what was happening is that lungs were getting fed. They don't need feeding, they don't want feeding, and people were dying as a result. So in hospital, when an NG is placed, there's none of this putting a stethoscope over and injecting air down and doing the whoosh test, that sort of stuff. The markers of an NG that's in place are you aspirate some fluid, you put it on pH paper, and it needs to be 5 or 5.5 or less, i.e. acidic, to be used. And if you can't get an aspirate, you get a chest x-ray, and there's a set way of going through the chest x-ray to confirm it's in the right place. The way that you might read about measuring for an NG tube, if it's nasogastric, is the next measurement, so nose, ear, and Ziffy sternum, so quite obvious landmarks for placing it. You imagine with the Ziffy sternum, although it's quite a good bony end point, it sort of sits at the junction between the esophagus and the stomach itself. And so the tip might be in the stomach or the bottom of the esophagus, but it's not really far in. Evidence after that has suggested that if you do the next measurement and add 5 or add 10, depending on your local policies, you're probably in a better position. So to do the next, if you're doing a nasal tube, you're going to have the port the way it's going to go in like that. Then you're going to measure from the nose around the ear, and then you're going to go down to the Ziffy sternum. And then at that point, the Ziffy sternum being maybe there on this chap, up around the nose, and then up around the ear, and then to the nose. And the point at the nostril here is the suggestive bit where it's going to be in the stomach. So in here it's 74 centimeters. Generally, in adults, a nasogastric tube is going to be in the right place if it's somewhere between 50 and 60 or 55 and 65 centimeters as a rule of thumb. If you're doing orogastric, you can obviously take a little bit of distance away from that, and I suppose sort of 40 to 50 centimeters, so less than nasogastric, is going to be a good indicator. I place most all my NG tubes in theatre, generally in anaesthetised patients with endotracheal tubes, and we keep our nasogastric tubes in the fridge, and we keep them in coiled in the packaging, so that when they're unravelled they're cool, so the plastic is stiff, and so there's no right angles in it, which makes the insertion a lot easier. You can see that by the nature of how we're working, we can't really do that, so we do end up with NG tubes, or gastric tubes, that have kinks in them and that are warm and malleable, so you are going to have a slightly trickier time with these, I suspect. In terms of sizes, you might see in hospital very small ones, so like 8 French fine bore tubes, through to sort of feeding tubes, perhaps 10, 12, 14 French, and then up towards like your general surgical abdominal issue needs a lot of drainage, like a Ryle's tube, so 16 or 18 French. This is a 16 French tube, so on the chunkier side, and I'm sure you can appreciate it is pretty chunky. So I'm either going to get my next measurement, or I'm going to measure orogastric. Yeah, it's roughly in the right ballpark, and then I'm going to insert it. So I'm going to have gloves on, obviously. Maybe the SOP was just eye protection, not too sure. Put some lubrication on, and then if you're going nasally, so there's a couple of options. You can just, on a hope and a prayer, ram it down the nostril gently with some lubricant and hope that it just finds its way into the right place. But as you can see, this is what happens, especially if it's got kinks in it. and especially if it's not cool, if it's warm. And so what happens then is you'll get this bouncing, you get this coiling, and sometimes the NG will come out of the mouth. And if you put it orogastrically, it can coil and then it just comes back on itself. So although nice if it goes in like that, I would suggest that the majority are not just going to slip in really easily. What you could do is take whichever intubation device you've used, DL or VL, and you can reinsert that. You can use the VL, place it back in the mouth, and then you get a view, and you're trying to get obviously the tube to pass posteriorly. That can be a little bit frustrating because you can see where the tube is, but the same problems with it bouncing, with it coiling, can be encountered. My preferred method is to get a direct laryngoscope, so it'd be the one that you've been using. Place it in the mouth, and you're trying to bring the airway and the tube in front of the esophagus and where the tube's going to go. So you're kind of obliterating the places where you don't want the tube to end up, like so. So you get a view at the back of the mouth. I can see the uvula dangling down at the back. So I put that in first, and then I just, with direct vision, place the NG tube and just sit just poking down in the back of the mouth where the uvula is. And then I take a pair of, you can try inserting it like that, but you can just get frustrated because you can kind of see where it should go, but it'll just end up bouncing. You take some McGill's forceps really gently to not grab the uvula, just passing it. And then if you can sort of visualize, you're not looking for a grade 1 view, you're looking for quite a poor view. You're just trying to get it into that potential squishy space behind the vocal cords. And you can kind of visualize it as it goes down. You just really gently, a couple of centimeters at a time, just pass the tube down in a straight line. And with that, you can get a feel for it. There's no resistance, and you're going to go in until either you see sort of bile or gastric contents coming up the tube, if it's under pressure, or until you reach your nex or your oral measurement.